Good evening and welcome to the Cancer Education Series brought to you by MercyOne and the Above and Beyond Cancer. My name is Chris Goodale and I'm the Executive Director of Above and Beyond Cancer. And we're excited to announce that our program is also being supported by the Iowa Cancer Consortium. And we're very proud to have received a grant from them to further our work. So it's my pleasure, as it is every week, to introduce our founder, Dr. Richard Deming, who will introduce our speaker. Dr. Deming?
Good evening, everyone. Thanks for joining us. We've got a really informative topic tonight. I'm actually looking forward to this. I know I'm going to learn a lot tonight. There's many different types of health professionals that are part of the team when people go through their cancer journey. And in the world of cancer, sometimes we have cancers that involve the pelvis, and that could be gynecologic cancer in women. It could be bladder cancer, prostate cancer in men, rectal cancer, anal cancer, lots of different treatments that involve the pelvis. We actually have a specialty of physical therapists who help work with pelvis, and they're called pelvic floor specialists. And we happen to have a really great one at Mercy. She happens to be out at the MercyOne Comfort Health Center for Women. And I'd love to introduce you to JoAnn Green. JoAnn's an Iowan. She grew up in Clarinda. And she's a cyclone. And then she went to Des Moines University where she got her physical therapy degree. And after practicing general physical therapy for a while, she got a specialty in physical therapy for pelvic floor disease. And the title of her talk tonight is Conquer Cancer from the Floor Up, Physical Therapy Intervention for Pelvic Floor. And without further ado, I'll turn it over to JoAnn Green. Thanks, JoAnn.
Thank you, Dr. Deming. Hi, everybody. As Dr. Deming said, my name's JoAnn Green. I've actually been with Mercy for a little over 27 years and doing physical therapy, and in the last 18 years have specialized in women's health. So actually the picture up there, I keep meaning to change it, but it just kind of shows you how long I've been doing this. My children there, Brady and Kara, are now 18 and 20. So we've been doing it a little while. So yeah, we are going to talk about conquering cancer from the floor up. And that floor is going to be your pelvic floor with an emphasis on how physical therapy can help. So physical therapists really play a unique role in the cancer care team because we really aren't treating your cancer. You have your medical team that treats your cancer and does the surgery and all the medications to save your life and let you lead a functional life. But sometimes there are challenges with those as a result of the cancer and the cancer treatment. And that's where the physical therapist comes in and hopefully can help you overcome some of those challenges that you have faced post-cancer. So we're going to talk about pelvic floor health. Two of the main things that come out of cancer of the pelvis are urinary incontinence and pelvic pain. So that's going to be our main focus today. So our objectives are to kind of just categorize some of the types of cancer that are in the pelvis that we see a lot, and then how do those cancers affect the pelvic floor. Again, two main kind of things that we're going to kind of divide into is that pelvic floor dysfunction related to weakness or decreased tone, which can be the incontinence, or you can have hypertonicity or increased tone, which can create pelvic pain. We're going to talk about the physical therapist and how we can use strategies and exercise and things to take away that pelvic pain or reduce the urinary incontinence. And then I'm just going to kind of finish up with kind of some effects of cancer on general health that you can still get care from a physical therapist, just your general physical therapist versus a pelvic floor specialist. So let's talk about some of the types of cancer. As Dr. Deming mentioned, the areas of the pelvis, uterine cancer, ovarian, cervical and vulvar that involve women. Now, breast cancer is not in the pelvis, but some of the treatments that we do for breast cancer, like estrogen suppression, can create some issues in the pelvis. Colon and rectal cancer, that can be male or female, and then male prostate and testicular cancer. So how does cancer affect the pelvic floor if we suffer from some of these types of cancer? Well, there is a pharmacological aspect. So your physician's going to treat you, and sometimes the ways to really take care of the cancer, prevent it from returning, is estrogen suppression, testosterone suppression, which for women, one of the things is a premature menopause. So how does that affect your pelvic health? Radiation could be a part of your cancer treatment plan. And any radiated tissue can create some immobility, some tightness, which can be painful. You can have scarring from radiation. If the tissue is changed, it can change how those muscles work. So maybe it inhibits it, or we get some muscle incoordination from the surrounding tissue. For men, it can create some erectile dysfunction. Surgical. So certainly we may surgically be removing the cancer. And in this way, if items or body parts are removed, it can eliminate some internal support because we have to cut through connective tissue or ligaments. Again, whenever we have surgery, there's an inflammatory healing process that can affect the surrounding muscles and inhibit it or change the coordination between the surrounding muscles. Certainly scarring can develop, and how is that, or may that possibly have an effect on the tissue? It can create just generalized weakness from having surgery. We have to recover from the surgery. In the pelvis, because everything is so closely related, even if you may have a hysterectomy, it's very close to your bowel. So maybe we have some gastrointestinal irregularities. Certainly with colon or rectal cancer, those things are going to be changed. And then there's always a chance of nerve injuries. With prostatectomy, we always try to do nerve sparing, but sometimes that's not possible. And if those nerves are injured, again, we can have issues with some erectile dysfunction. So understanding those effects of cancer on the pelvic floor is going to help us treat that. And again, dividing into two main categories to kind of simplify it is you're going to have some muscles or some effects of cancer treatment that may cause the muscles to be weaker, not have as much tone. Again, surgical remover, maybe we've cut through some ligaments, so we lose some support. And that can create prolapse, where something's kind of falling that shouldn't. Or it can cause incontinence, and that can be both urinary incontinence or fecal incontinence. If the muscle from radiated tissue tightens things up, or pain, then the muscle can become too tight or hypertonic. And if we have increased tension, it may create painful intercourse for vaginal penetration. We might have difficulty relaxing our external sphincter or the muscle surrounding the pelvic floor to defecate, and it causes some constipation issues. And then pain is a big side effect of those muscles being tight. So we want to have a picture or a clear understanding of pelvic anatomy so that we can kind of understand a little better those effects as well. So first we're just looking at the pelvic, the bony part of the pelvis, which is actually two pelvic bones and the sacrum. The sacrum is that triangular bone at the base of the spine. And then there's all these layers of muscles and fascia and nerves in there that again can be disrupted from radiation or surgery or any of those things. So they all layer through there. Here, if we look at female pelvic anatomy first, so I don't have a pointer on Zoom, but if you go to the picture on the left, that's a side view of a female pelvis. And if we start at the left, we will see the rectum. And then moving forward, you see the urethra, and then the uterus in front. And then you'll, if you go farther, you see that bladder. that you see the pubic bone, the bladder sits right on top of the pubic bone. The pubic bone is kind of that little white oval towards the front. Then if we go over to the right, we are looking from the bottom. So if someone's lying there at the bottom, we see the rectum and the muscles, that superficial muscles there with the vagina, the urethra, that little red spot, and the above it. Now, these tissue, the tissue between the vagina and rectum is called the perineal body. And it's important because we have a lot of muscles that come and attach there. So this kind of gives you just an idea of where that's all sitting. Here again, this is gives you a diagram that's more labeled if you were having trouble differentiating. On the side view on the left, it shows where the pelvic floor muscles are, and it shows a little dripping that maybe they're not able to contract and you have some leaking. But it shows you it's flipped from the other one. So the bowel is to the right of the picture with the uterus in front and then the bladder. And then similarly, looking at the bottom view where we see where that anus is up into the vagina and the urethra. Now for our male pelvic anatomy, there's certainly some definite differences here. And when we talk about prostate cancer and removal, if you look on the left, again, to the right of the left picture, we see the rectum, and then forward we see the bladder, and that urethra going the full length of the penis. But right under the bladder, on the picture is kind of an orangish yellow color, that's the prostate. And so men automatically have a support structure there that is the prostate. Men don't have a lot of difficulty with incontinence if they have that structure to support, as well as the longer length of the urethra allows for better control. But if we remove that prostate, then we lose that support structure, and we see a lot of men struggle with incontinence there. On the right, again, the pin on this one is showing that perineal body, or that tissue that is between the anus and the urethra at the base. So what's the pelvic floor do for us? What's its function in day-to-day living? Well, first, it supports everything. So you have ligaments and connective tissue that help support all of those, the bladder and the rectum, vagina in women. But the one thing you can do to control is pelvic floor. So if you lose some of that support, you can strengthen your pelvic floor. You have control of that. The other thing it does is it provides sphincteric tone. And the sphincters are just those circular muscles around the urethra and the rectum. So it gives you the control. If you don't want to urinate, you tighten that muscle, right? If you don't want to pass gas, you tighten that muscle. So it provides that sphincteric tone. And then it also provides sexual tone. So for females, anything going into the vagina has to go through the pelvic floor. So if it's tight, it can be painful. If it's weak, you lose sensory input. So functioning, to have a normal functioning pelvic floor, it needs to contract or shorten. It needs to be able to lengthen or bulge, and it needs to be able to relax. If any of those things are disrupted, it turns into symptoms related to, again, constipation, incontinence, pain, all of those things. You have to be able to maintain a certain amount of tension for continence, right? You have to be continent all day long, so that pelvic floor has to have a certain amount of tone for support. And we find that many patients, if you are asked to perform a pelvic floor muscle contraction, which is a Kegel, if you've heard of Kegels, if we have you ask you to perform that, it's done incorrectly, and I'll have some more statistics on that in a little bit. So we have supportive dysfunction. It's supposed to support, and that can be because the pelvic floor is weak, we lack support, causes prolapse or things to fall. Any of this can happen, right? Surgically, radiation, any of those things for cancer treatment. And that can create some urinary incontinence, the lack of tone. We can have some fecal incontinence there, and again, decreased sexual tone. So when we have supportive dysfunction, it is some type of loss of the nerves, the muscle, ligaments, the fascial integrity through there. So again, if we have surgery where we had to remove something, we're cutting through those tissues. Hormonal imbalances from medication, are we doing some suppressive things or other medication that has an effect? Trauma to the nerve, the muscle, the fascia, that radiation can cause trauma, the surgery can cause trauma, all of those type of things. Repetitive stretch and strain, maybe not quite so much in the cancer side of things, but anytime we put any added strain consistently, that can create some supportive dysfunction. So what are some symptoms that you might be experiencing that could be pelvic floor related? Well, incontinence, again, dribbling. So maybe I go to the bathroom and then I dribble a little bit after I urinate. Or I feel a heaviness vaginally or perineal heaviness, falling out type of feeling. Maybe I don't feel empty after I void. So I go into the bathroom with urge, I empty, but don't feel like I completely empty. Or stand up and then feel like I have to turn around and sit down, or go to wash my hands and have to go back. Low back pain. We're going to talk a little bit about surrounding muscles. And if you don't have good pelvic support and pelvic stability, again, we'll talk about abdominals and things, but if your pelvic floor is weak, you're not supporting your pelvis or your back, and that can create some lower back pain. It can also create pelvic pain. And you can experience some fecal staining, which can be again to weakness through that pelvic floor. Prolapse is where something is falling out. So we've lost some of that, again, tissue integrity, where maybe a ligament was cut during surgery, or we've removed something close by. Again, maybe we've removed the uterus, and then that creates some lack of stability at the rectum or the bladder. So this is just a cystocele's bladder falling. You can have the urethra or the rectum fall, certainly uterine prolapse, and again, that's that heavy kind of falling out feeling. So some of the related anatomy. So we've talked a lot about the pelvic floor, but there's also anatomy surrounding your pelvis, certainly that can be affected by the cancer treatments, but these muscles all coordinate or have a synergistic contraction with your pelvic floor. And they are your diaphragm, which is the big dome-shaped muscle that helps you breathe, and your abdominal muscles that I already kind of alluded to, and hip musculature. So if we think about the diaphragm, again, the diaphragm and the pelvic floor, they're going to work together, and they help with both breathing, respiratory, and postural, so postural muscles. And if this relationship between those two muscles is inhibited, then the pelvic floor and the viscera can be negatively impacted. So again, depending on what our cancer treatments were, this can have an effect there. During inhalation, so when you breathe in, your diaphragm descends as well as the pelvic floor. So we want that to work together. And if you're not breathing correctly or not using your diaphragm, then that can lead to inappropriate muscle activation. And if we have inappropriate muscle activation, it actually can cause some overfiring of the pelvic floor, which could lead to tightness and some of the other pain and symptoms that we're experiencing. The abdominal muscles. They seem to be around for everything, right? The voluntary activity of abdominal muscles increases activity of the pelvic floor, but mostly the lower abdominal, your transverse abdominis. If you can complete a pelvic floor contraction with a gentle lower abdominal contraction, it really maximizes that support. So as a therapist, we can help you isolate that if you need additional strength and control. We don't want you overutilizing your other, maybe rectus abdominis. You actually have 4 different abdominal muscles. So we want to just make sure you're using those correctly. And then there are lots of hip muscles. So a lot of muscle attachments at the pelvis. These are more anatomical in nature as far as the names that are here: piriformis, the obturator, internus, externus. So those muscles rotate the hip. You've got your thigh muscles, right? The thigh muscles on top. You've got inner thigh, groin muscles that attach, your hamstrings on the back of your legs, your glutes or your buttocks. All of that can have an effect in surrounding it. Specifically, the inner thigh, or those adductor muscles, and your glutes, the buttock, they have a synergistic contraction with your pelvic floor. And if the other muscles that are being affected in the hips, they actually can have a referred pain pattern, which just means one area. So maybe an area on your inner thigh that can refer pain to the pelvic floor, which makes things difficult sometimes. You can also have pelvic floor tender points that refer pain out. So you might have something going on in your pelvic floor that refers pain to your hip. So again, can be a little complicated there. So now we're going to kind of switch gears. We've kind of talked about what the pelvic floor does. We've kind of went over anatomy a little bit, so we have a better idea of where we are. One of the main issues with cancer treatments of the pelvis is we end up having leaking and having incontinence. Well, incontinence really, right, it's just the loss of urine when we don't want it to happen. So it's a social hygienic problem. This is a general, this isn't cancer, I have another slide, but 15 to 25 million Americans suffer from incontinence. 80% of women will have some form of incontinence in their life. 80% of incontinence is treatable, male and female. Women, this statistic, from 30 to 59 years old, 26% have problems with urinary incontinence. The male statistics have a larger range, so it's not a great statistic, is why I didn't put that up there. But here we see incontinence may occur after surgical treatment of rectal cancer, certainly, as you saw where that muscle was. And then 34% of women treated for the three main gynecological cancers, so cervical, endometrial, and ovarian, can end up with urinary, or do end up with urinary incontinence. And there's also, again, kind of a range of males for statistics on post-prostatectomy, but that's where we see a lot of the male incontinence. So what helps, or how can we be continent? So this is kind of the normal. We're going to kind of go through the normal to see what abnormal is. And really, to be continent and not leak, you have to store your urine, you have to be able to transition yourself to the bathroom, and then empty. And all that takes muscular control. So when you're storing it, the bladder's going to fill with urine, right? Your kidneys are your filtering system, and it fills. Normal voids during the day is about 2 cups. So if you wanted to see what your normal void was, you would sit on the toilet or stand if you're a gentleman, and you're going to count how long it takes you to pee. Now, you're going to count good stream, so no dribbles, start, stops. You're going to have a solid stream, and you're going to count. I use the 1 Mississippi, so you can say 1 Mississippi, 2 Mississippi, and you count. And if you're in that 8 to 10 range, that's a normal amount during the day. The bladder is going to tell you when you're, signal the brain that your bladder's full, and it does that through little stretch reflexes. So if you think of your bladder as a balloon, it's going to slowly fill and stretch, and then those stretch reflexes say, oh, I think I have to pee. You get that feeling of fullness, and you transition. And transitioning is just recognizing that you have to go, being able to have enough tone in your pelvic floor or tighten your sphincter to transport yourself to the bathroom without leaking, and then it's time to relax. And at that time, you're going to relax your pelvic floor sphincter, the bladder is going to contract, and you'll void. Now, there's always a chance you can have a little. We consider normally, after you go to the bathroom, you can have up to 50 milliliters of urine there. But if you're not feeling empty, they can do an ultrasound of the bladder and see how well you're emptying. That just kind of gives you an idea that sometimes there's a little bit left, and that's still normal. So normal, again, talking all about the normal stuff, so we can understand abnormal. Bladder function, again, it's stored. We had to potty train when we were little, so the good news is we can retrain it. It's a muscle that can be trained. You never want to have to push or strain when you urinate. You know, when we defecate, there's some of that, but for urination, we don't ever want to have to strain. We want to be able to just sit and relax. So if we're straining, we need to look at what may be the cause of that. That first urge, so those little reflexes in the bladder will first tell you, oh, maybe I could go to the bathroom. And it's normal for most of us to ignore it because we're in the middle of a meeting, or we're in the car, or we're doing something else. And then that will continue to fill, and you'll get a stronger urge. So frequency is going to be about every 3 to 4 hours. Now that's if you're getting good fluids, normal fluid intake, you're not having any infections or anything else going on. You will, with age, get a little bit of slight smaller bladder capacity, but still frequency should still be every 2 hours. So if you're finding yourself going multiple times a day, then we should probably take a look at that. So normal, 6 to 8 times a day, if you're going that every average 3 hours. Full bladder, 8 to 10 ounces. So for every second you count is approximately an ounce. That's that 8 to 10 Mississippis. And your first morning void, your bladder will hold up to 20 ounces. So your first morning void is going to be greater, and you shouldn't have to get up at night to go. So that may be habit forming or something else going on that's causing the bladder to get irritated if we're getting up a lot at night. Common conditions treated with the bladder, as far as the urinary issues, certainly leaking, we just talked about. You can have urgency and frequency, so you might be going all the time, not leaking, but it's just frequent. Hesitancy, that's a different side. So if we feel the urge, we sit down and we can't start stream, that is another issue that we need to address. Again, incomplete emptying. Do we not feel like we're empty once we go to the bathroom, or we feel like we're retaining urine? We can have urethral pain. We can have painful urination, and that's another area to look at. And then detrusor instability. Detrusor is just your bladder. It's just another word for your bladder, but that can be overactive where you're going more frequently as well. So the types of incontinence that we treat are urge incontinence, stress incontinence, and a combination of both. Urge incontinence is when you get a strong urge, like you can't wait and you're rushing, can't get your pants down fast enough, so you might leak or dribble, and it's very quick. It's a few seconds. You don't really have a warning. That's when the bladder contracts without it involuntarily. This is called overactive bladder. Again, it's frequent, or detrusor, bladder instability. So you may have heard those terms. And a lot of times we have triggers with this. So we might step outside and get a cool rush of air and pee our pants. And we're like, what just happened? Or running water, putting hands in water. Another common one is we call key in the door. So you might feel fine until you pull into the driveway, you get into the garage, and then all of a sudden you don't think you're going to make it from the car into the house, or to open the door, because you get that strong urge. So you want to ask yourself, are you leaking on the way to the bathroom? Like you just can't get there quick enough and already dribbling. You're rushing, again, can't get my pants down fast enough. I get there, but then I can't quite hold it. Or you just have that, it's no warning, just kind of hit you again with a full blast of air or something, and you weren't expecting it. That can be some bladder instability. Stress incontinence is really related to pelvic floor muscle weakness. This is when you lose urine or leak with some type of physical exertion. So there can be an increased intra-abdominal pressure, which can occur with your sneezing, coughing, lifting, maybe just getting out of a chair. It's that effort. Do you do exercise, jumping jacks, right? Or I can't run without leaking. That just means that pelvic floor is weak. And do you leak during this situation, the provoking situation, as I'm sneezing, or is it delayed? So those are kind of things that will kind of guide us to what's going on. And then you can have a combination of both, where you have a lot of urgency, can't get there fast enough, and you also leak with sneezing, coughing. So that can be a combination thing. So we've established incontinence. So if we're leaking urine, what are we going to do about it? So from a physical therapy intervention, we're going to go through the evaluation, right? Find out what is going on, and then come up with a treatment. And then once we have solved the problem, we need to be able to maintain it. So just a couple more informative slides. The AUA, or American Urological Association, recommends the first line of treatment is behavioral therapy, which is your physical therapist. So we do bladder training, control strategies, behavioral modifications, pelvic floor muscle strengthening, fluid management, all of those things that we can teach you. Female pelvic pain and urinary incontinence. This is just a study of 889 articles were reviewed. 25% young women, 44 to 50% middle-aged and menopausal women experience urinary incontinence, and 75% of women in the nursing homes. Here, pelvic floor muscle training alone is as effective for stress or mixed, so that combination of incontinence, when adding biofeedback, electrical stimulation, and bladder retraining. Evidence is lacking to support surgery for pelvic pain. Again, that's where we come in. Nocturia is just getting up at night to void. So it's nighttime voiding. Again, we shouldn't really have to get up at night. Our bladder should have the capacity to hold until morning. But if we do experience that and we're getting up at night, what are some of the other things that can happen? It can increase our fall risk. If we fall, it can increase our fracture risk, which puts us at a mortality risk. So behavioral treatment and bladder relaxant therapy, which can involve medication, is better than just doing medication. And this study was specifically done in men. So what can you expect? You are leaking, you've talked to your doctor, and it's time to go to physical therapy. Well, it's an appointment like any other rehab appointment. You can bring your loved one to be there for support, and you're just going to really share the issues that you're having, and we're going to develop goals for, in this case, maybe just not leaking, right? And then we'll talk about options for treatment. So we're going to start with an evaluation, and that evaluation is going to incorporate a good history. So why are you leaking? Were you fine until you had that hysterectomy due to cancer? Were you fine before you had that prostate removed because of cancer? Were you fine before all of those treatments, and now the side effect is leaking or pain or whatever it is? So evaluation here is going to be the same whether you're having leaking, and in a minute here we're going to talk about pelvic pain. But we're going to evaluate everything. We're going to evaluate all of the surrounding muscles, those hip muscles that we talked about, abdominals. We're going to look at pelvic symmetry. So those original bones I showed you on anatomy, those sometimes can get twisted. We want to make sure they're all lined up the way they should be. Sometimes just a surgical position can create some of that pelvic rotation. What's our strength? What's our mobility? If you have surrounding tight muscles or weakness. And then what about scars? So could be abdominal scars from surgery, could be any of your surgical scars. And what's tender? We're going to palpate or push on different areas to find out what we need to treat. So who presents to physical therapy in general from a pelvic rehab standpoint? Well, this was over 2,000 patients in over 100 clinics, and we saw, again, largely urinary issues, 67%. So that's why we spend so much time talking about that. bowel less, 27%, and then pelvic pain a little higher at 39%. Again, here kind of just breaks down some of those urinary issues. The leaking is primary, but a lot of trouble with frequency as well, and that urgency. You can just kind of see some of those numbers there. So we are leaking, and we need to know what's going on with that pelvic floor because it's your primary muscle for control. So we're going to check the muscle strength. We're going to see how well you can hold it. Is there any pain or tenderness there that is creating some muscle inefficiencies? And can you contract appropriately? Studies tell us that we can be told to do a contraction, but we do it incorrectly. And then reflexes. So if we think about some of those cancer surgeries or treatments in radiation and those kind of things, the nerves can be involved. So we can check reflexes too to see how those nerves withstood some of that cancer care. Here, just another picture of how close in proximity all of those pelvic organs are. So if we work on one, remove one, treat one, it can affect those close. So if we think, again, in a little detailed pelvic floor anatomy, it's called levator ani. So if you're looking things up, levator ani muscles, pelvic floor muscles, it's the same thing. It's 3 muscles. And it supports the pelvis. We talked about that. It gives tone to those vaginal rectal canals. It is 30% of fast twitch muscle fibers, which is that rapid response. So if I sneeze, it's going to catch me. But we need to be continent all day long. So 70% of them are slow twitch. That just maintains that tone. So I can walk around during the day and have support. And again, sometimes that's lost with different things that we have done during that cancer treatment. Kegels are very important. They are very key when we start talking about controlling the leaking that may be a side effect of our treatment. So we're going to do some pelvic floor strengthening. We want to make sure that we're doing it properly. How are we contracting? And we can change positions that we do our Kegels in to add resistance. So it's going to be easier if I lie down, but it's going to be harder when I'm standing. But I need to be continent when I'm standing because that's how I'm functional. Pelvic bracing uses that pelvic floor and abdominal area to brace for sneezing, coughing, lifting, some, again, those functional things that we do where we might find ourselves in a position where we feel like we might leak. And then advanced Kegels is just some combination things that kind of give you that test, because anytime we strengthen a muscle, it's progressive resistive exercise, so we want to progress that. Here's just a slide that tells us statistically 40% of women do an ineffective effort on their pelvic floor tightening, and 25% of them do it incorrectly to the point they're incontinence promoting. So instead of pulling the muscle in, they're pushing it out, which weakens it. So they actually make it worse. And that's a lot. That's 1 in 4. And they have found also in studies that a significant number of healthy young men were unable to perform a proper pelvic floor contraction standing, again, very functional, or side lying. So we know we need to retrain or train men and women to use these muscles appropriately. So pelvic floor strengthening, progressive resistive exercise for women. There are some vaginal weights we can use, and that can help with strengthening. So again, kind of changing gear just a little bit. So now we're going to strengthen the pelvic floor. Well, what if our pelvic floor is fairly strong, but the bladder is overactive? Then we're going to look at more behavioral modifications. And to really understand that, we are going to maybe do a bladder diary. So you're going to write down when you go, how much you go, when do you leak, when do you not leak, what's your diet. So your diet can have an effect. We'll talk about that in a minute. Fluids is big because we are primarily water. We need lots of water. So what's your hydration? But we find that people that are leaking often say, well, I'm not going to drink as much because then I'm going to leak more, which isn't the case. And then urge, are you rushing? So what's going on? We want to avoid constipation. So if we're having bowel stuff, how does it affect bladder? If we're straining because we're constipating, we're pushing out on the pelvic floor, which means we're weakening the pelvic floor, which can, again, cause some urinary issues. High fiber diet, that's an easy answer to that, but we can certainly look at other nutritional aspects for that and the GI system. You should never have to push or strain to urinate. So if you are straining to urinate, we need to address that with our physician because that should be happening. Sitting on the toilet for women, if you do not sit, if you hover, you don't like to sit on the toilet in a public restroom, you don't completely relax your pelvic floor. And if you don't completely relax your pelvic floor, you don't completely empty and you're back in the toilet. For men, if I have male patients that maybe are having pain or some issues, sometimes it actually helps them to sit on the toilet because most of our male patients stand and they're using different muscles. We use different muscles when we stand versus sitting. So sometimes sitting on the toilet may be good for our male patients as well. No just in case peeing. Just in case peeing is a habit that we can start that can create other issues with the bladder. So just in case is when you go to the bathroom without urge. So you might be going to the grocery store and you don't feel like you have to pee, but you decide, I better go just in case. Well, when we do that, we create some hypersensitivity in the bladder, which causes us to have to go more frequently. So it can increase frequency. Going for 8 Mississippis, that's where you're trying to find out whether your bladder's full or not. The one time you get to just in case is before and after sex. That's to prevent urinary tract and yeast infections. So fluids, how much should you be drinking? Everybody hears 8-ounce glasses of water a day, and I would love if everybody did that. But we're not all built the same, and our activity levels are different. So I don't think a 200-pound man should be getting the same as a 130-pound woman. Or if I have somebody outside sweating, working, versus somebody sitting inside reading a book. So the best way is to really look at your urine. It should be clear to pale yellow and avoid that odor or dark color. A good rule as far as body size is half your body weight in ounces of water. So if you're 150 pounds, you should be getting 75 ounces of water. Now, you don't only have to drink water, but 2/3 of your daily intake should be water. So let's say you're getting the 64 recommended, then you could drink another 32 ounces of something else and still be okay as far as fluids and quantities. So this is a list of things that can irritate your bladder. Again, whenever we have surgery, chemical changes, radiation, all of those things, sometimes it can create changes in our body. And these are irritants to the bladder itself. It's very individual. I like to drink Diet Coke, which isn't good for me, but it makes me pee because it's caffeinated, carbonated, it's got artificial sweeteners and colors. But coffee doesn't seem to bother me. So it is individual. These are primarily things you drink, but there are some things that we eat, which is more those tomato-based things if you cook with curry or spice. Otherwise, again, mostly things we drink. It can be decaffeinated. A lot of people just think if they decaf their coffee. So it can be that with the tea as well. Milk can be an irritant. And then again, those caffeinated, carbonated things. Chocolate is on there because of the caffeine, can be an issue for some. And then citrus. So if you like to eat oranges or you like to put lemon in your water or you like lemonade, sometimes that can be an irritant as well. So something just to be aware of. So if we have a bladder that's overactive or making us pee all the time. 3 of the things that you can do. One is try mind over, we call it mind over bladder, really distract yourself. Take your mind off it. You can try counting backwards from 100 or saying the alphabet backwards, anything to kind of distract yourself from I gotta pee, I gotta pee. We have a nervous system response that can create an urgency. So if we get more stressed about, I've got to go right now, it actually increases the bladder contraction. So if you relax, take a deep breath, it slows your heart rate, brings your blood pressure down, and relaxes the bladder muscle. So deep breathing. And then that Kegel again. Your bladder and your pelvic floor cannot contract at the same time or relax at the same time. So if your bladder's contracting, telling you you need to pee, and you do a Kegel, it will have to relax during that time, and then sometimes that urge goes away. Biofeedback we can do in the clinic and put just surface electrodes, or we can do vaginal or rectal sensors. That just gives you visual feedback. You look on the computer if you're having trouble with a muscle contraction or relaxation, and it tells you what the muscle's doing, so it allows better muscle isolation. This is a handheld biofeedback. Again, in the clinic, we use a computer, but there you can kind of see the sensor and what that looks like. We've already kind of covered the accessory muscles that we'll evaluate in abdominals and hip and glute area. Other treatments that we might be involved in, depending on what we find on that evaluation, is stretching if things are too tight, if we've got some muscle incoordination, scars. We got scars from surgery, some pelvic asymmetry. Definitely want to look at that diaphragm or giving some more pelvic stability. If we are having leaking issues, just protecting that skin, which may include a barrier ointment, pads, that kind of thing. So this is the other side. So we just talked about incontinence, weakness, all that. What we find a lot of times with those cancer treatments, radiated tissue, it gets tight, it scars down, scars can tighten up, and we can have pain. So pelvic pain is tightness of the pelvic floor muscle, and its primary symptom is pain. So the causes, again, radiated tissue, surgical traumas, those hormonal imbalances can create some vaginal atrophy, which then causes problems with intimacy. Symptoms, you'll notice they're all pain, right? Back pain, vaginal pain, rectal pain, abdominal pain, coccyx pain, which is your tailbone, painful ejaculation, testicular pain, pain in the thigh, vulva. Those painful things can be related to a tight pelvic floor. And if it's tight, it can create issues with defecation and bladder. So what makes treatment difficult with this is that your pelvic floor, because of the position of it, it doesn't cross a movable joint like your hamstring or other muscles in your body where you can show you a stretch to move the tissue and lengthen it. So to stretch the pelvic floor, it has to be done internally or some external techniques to kind of start that loosening process. When we have a tight pelvic floor, it involves sexual health. So one of those things post-cancer that can affect our return to intimacy can affect 3 aspects of sexual health, including desire, arousal, and climax. Desire can be limited because of a number of things related to cancer, right? How are we responding to cancer treatments or post-cancer? That hormonal component that can decrease our libido. Now I have a surgical scar. I've lost a body part. I don't feel the same. Maybe I don't have hair at the time. I have fatigue, chemically induced or just, from basic trauma, stress, nausea created by chemo. Maybe my weight has changed. I don't feel like myself, and certainly anxiety. We're going through a stressful time. Arousal from that, again, pain. It can be from radiological burns, that pelvic tension, vaginal dryness, If I'm tired, I'm going to have more difficulty with arousal. Maybe I'm leaking and I'm worried I'm going to leak during an intimate moment. And certainly erectile dysfunction for men. And I think all of them just go right into the climax component, those same things: radiated scars, the anxiety, the fatigue, the pain. So sometimes return to intimacy is difficult because of what's going on through the pelvis or any cancer treatment. Erectile dysfunction, this just has another study in pelvic floor strengthening that showed a case series in 2009 that just indicated that pelvic floor muscle exercises can help improve erectile function in men after radical prostatectomies. And the psychological and sexual counseling can really be beneficial as well. So treatment with the tight muscles, right? We're mobilizing it. Maybe the joint structures surrounding it are tight. We can use modalities like ice and heat. We're going to relax that pelvic floor. So no Kegels for this one. This is relaxation. Surrounding pelvic stability, stretching, posture. We talked about how the diaphragm and pelvic floor are postural related, so we're going to work on that. We can use the biofeedback and sensors to help relax everything. If we're having trouble with that relaxation, massage techniques, all part of the physical therapy treatment options. So with this, again, we're trying to relax the pelvic floor. It's too tight. So we're going to use the diaphragm to help us create better muscle awareness and coordinating. And we want to be able to do those three things. We want to be able to contract the muscle, relax the muscle, and lengthen the muscle. Jaw drop is an interesting factor, and we know that if you clench your jaw, it clenches your pelvic floor. So I usually have people try this. I don't know if you're all still with me. I usually stand up, but you can do it sitting. If you clench your jaw together and you pay attention to what's happening in your pelvis, what you'll find is when you clench your jaw, everything tightens up below. And then when you relax your jaw, it seems to let go. So it's just a nice way to feel and assess how things, you're all connected. You're a whole person. And sometimes if you're not relaxed here, you're not relaxed in your pelvis either. So that's kind of primarily what we're talking about with pelvic floor. Again, we kind of talked about weakness, incontinence, and tightness for pain. These are just other physical therapy interventions. There's all types of cancers. There's all types of consequences of treatments and things that allow us not to function the way we want to. So physical therapy can help you if you're still suffering fatigue. Maybe you have struggled with balance and falls or general weakness, back and hip pain, any of those pain kind of things, abdominal weakness. We have some great lymphedema therapists here. I don't do lymphedema, but our occupational therapists here, Tammy Stebbins and Amy Sandhurst are here, and then we have a certified occupational therapy assistants here at the Women's Center if you're struggling with that swelling because you had lymph nodes removed. Osteoporosis is just another thing. And that's all I have. That was enough, right? So any questions at all?
Jen, this is Dick. That was awesome. I learned a lot from you. One of the fundamental questions I might have is when you're working with a patient, how much of what you do is teaching patients habits and exercises that they do on their own versus how much of your therapy is you hands-on working muscles or fibrosis?
Yeah, I think it just varies, right? If it is an incontinence where it's a weakness, a lot of times once we establish good muscle contractions and we know they're doing it properly, so much of that they can do on their own. Once we get them using the right muscles and how to use them, a few behavioral things maybe because they're drinking too much coffee or not enough water. But most of my incontinence patients, we might only see 3 to 4 times, and the rest of it, they're really doing it on their own. Pelvic pain sometimes is a little different because it's a tightness in the muscle, and sometimes that requires more hands-on in the clinic to start. And then again, we're gonna definitely teach them some behavioral things they can manage at home. But a lot of the pelvic pain is a little more difficult just because it can involve a lot of the surrounding muscles. So how much is the hip involved? Do we have a lot of scarring? And those kind of things. So I think that's a little more variable. But we're always going to have a good home program. And once we establish our goals, then teaching maintenance, so that how do we maintain what we've gained so that we don't end up having more issues later on.
Seems like a sort of a life commitment as well, right? It's sort of like ongoing good health practice, right?
Yes, like anything, right? We have to manage, but sometimes I think those, that cancer, we get through the cancer, that was that, oh my, life threatening, here we are, and we get through that, and then we find ourselves on the other side and maybe not functioning the way we thought we would. And I just want people to know that, it doesn't mean you have to give up on some of those things. And that's where you want to really talk to your doctors and your providers to see if something more can be done to get you back to where you were. Certainly every case is different, but a lot of times we can do things to help with some of those pieces that maybe, were affected with the cancer and the cancer care that we had, that ultimately got us where we were and saved us from that.
Well, and you've talked about a lot of serious issues, but you've also presented a bright hope for anybody who has an issue, that through some hard work and some pointed effort from a professional like you, you can really change things for yourself. I think that's a great message that Above and Beyond Cancer loves to share with people.
Yep, I would agree. Cancer care is not just about killing cancer cells. It's about taking care of patients and making sure that not only do we do the best job possible getting rid of the cancer, but that we make sure that people recover and get back to their best functional state. And that requires professionals such as you, physical therapists with specialized skills and talent. And we're just very fortunate to have you on the team. So I really appreciate you being here tonight. This has been recorded and will be housed on our website, and people can also find it on our YouTube channel and refer back to it and watch it again, or refer it to friends who might not know about this type of therapy. And if someone wanted to see you, would it require a referral by a physician, and can a primary care physician or a cancer physician refer to you?
It depends on their insurance, really. So Iowa as a direct access state, so a lot of Blue Cross, Blue Shield insurances, any federal or state insurances, you'll need a doctor's order. So the insurance check is primary, but if you're having issues, definitely talk to your physician and certainly ask if physical therapy might be an option for the issues you're dealing with. But yeah.
Very good. Thanks again. Thanks everybody for attending.
Yeah. Thanks so much.
Thanks, JoAnn.
Good night.
Good night.